Welcome everyone to the Clinical Leader's Guide to Communicating with Executive Leadership. And I'm Lizbeth Wetruba, the Chief Clinical Officer for Avasure and a third-generation nurse. And I brought in a physician colleague and friend of mine, and both of us are going to talk about how to take your clinical passion and insights and present that in an effective way to executive leadership. So I'm really happy to introduce Dr. Ethan Booker, who is the Chief Medical Officer of Telehealth at MedStar. Welcome. And Dr. Booker is a practicing emergency department physician, and then he finds time to do some other stuff, like being the physician executive for the National Center for Health Security and Resilience, which I got to learn about last week, which is very interesting and worth finding him next time you see him and ask more about that, about biocontainment and some emergency preparedness things. We serve together on the Center of Digital Excellence for the American Telemedicine Association. And that's where last fall, Ethan, I heard you speak on this topic and presenting and you kind of creating a business case maybe for the CFO or for the board is something that I work with every day with different clinical leaders across the country. But your perspective, I thought, was unique and real, keeping it real and really worth sharing. So let's dive into that and welcome.
Right. Thanks for having me.
Yeah. I think the first thing that really struck me when you spoke about this and really was the talk of the conference over lunch, like, oh, that was so interesting, was on the goal of communicating as a clinician with an executive board or CFO. And the goal is necessarily getting to, yes, what did you call the goal?
Yeah, we talked about getting to conviction, which is, I certainly didn't invent the idea, and lots of folks have described this. I think, one of the things that has been my experience as a clinician, as you point out, I still see patients in my urban emergency department, and I kind of have a sense of, this will work, this won't work, this will improve value, this will be better for this patient in this context, in this circumstance. And you have I really appreciate having the very granular view of taking care of a single patient at a time, because it does feel like it grounds my experience about what's likely to be beneficial. And I think the real challenge for clinicians is to scale that experience up to the executive level to get at the kinds of things that actually do make scale impact. And the kind of intuitive leap that you want to make, I understand this from my direct clinical experience and context, to the executive level, particularly as we're talking about really significant changes in care model, whether it's telesitting or virtual nursing or command center functions, or, we're talking about really substantial changes and infrastructure investments. To get to scale from my lived experience as a clinician, it doesn't always translate. And then the other thing that you often end up doing is really wanting approval from executive leadership. Wow, that's a really interesting idea. Or isn't that so cool that you're thinking about this? But that's not really the goal. The goal is to get to conviction, which is yes. And yes, we will fund this. We will fund this to this amount this year, to this amount next year. It's gonna go on our 5-year strategic plan. It's gonna go in our capital expenditure budgets, and getting to that conviction is the place where we often fall down. Because what tends to happen when you give executive presentations around these big muscle moves in your organization is, that's really interesting, or not right now. And in some ways, you'd rather have a clean no.
I agree.
Right now. But the conviction is the important part, and making sure that you actually, as what I talked about in that previous conversation, what we've talked about is to enter into an executive conversation with engagement right away. right? You have 10 or in those kind of board presentations or in front of your CFO, you have maybe 10 to 30 seconds. You have 2 to 3 sentences worth of painting a compelling picture. And then the tail end of that meeting has to be, yes, we will do this. This is how we're going to fund it. This is when we're going to fund it. These are the resources we're going to devote to it. And this is how it's going to be part of our strategic mission. Because most of the stuff we're talking about, if you're talking about putting cameras in every room and
Yeah.
remaking your workflow, these are major strategic goals. You can pilot this stuff, but you can't do it for real unless you're willing to really jump in both feet.
Yeah, and I feel like I'd rather get a no than to be in the purgatory of like, well, let's keep piloting it or let's keep working on it. And then you're doing it as a leader, you know, in addition to your day job off the side of your desk, trying to cobble something together without investments. And so the conviction part comes with action from the leaders as well. And I think and as well, coming from a nursing background, and also I would love research and evidence-based practice. So I have to remind myself not to get into the weeds and start out by impressing them with all the research that I've done or all the research that is there. So how do you what's the initial, if it is a presentation or you're able to talk to someone over lunch or coffee or something,
Mm-hmm.
what's that, and some ways to kind of initially get engagement?
Yeah, I think that one of the challenges, there's kind of a couple of challenges of sort of the innovation space, the care model redesign space, which is kind of where my job sits, is that we actually have the opportunity to see a lot of solutioning. And so one of the challenges is to make sure you don't come with solution, right? And what that looks like for me in the most part, particularly in the second scenario you describe of like, you have the opportunity for casual conversation, is to really start with question as opposed to solution, and make sure that you're engaging your executive leadership to make sure that they are saying out loud, what are their burning platforms? What are their big issues? Because if what you're doing is coming with a solution to the thing that's 10th or 11th on their list, they're not going to stay engaged. And if the solution you have is to that 10th or 11th thing, today's not the day. And I think the second part of that is actually to do what you've described there, which is kind of like letting go of the ego of the pat on the back for being very smart or clever about the thing. Right? You're like, you know, you're what I think of as my job, right, is delivering to a larger scale the best quality care, right? And so like I've been in this journey myself clinically from ER doctor, full-time ER doctor, seeing one patient at a time, thinking about the waiting room, thinking about a larger community, doing operations improvement, doing telehealth, doing advocacy policy, because like I'm in a journey towards broader scale, broader impact. And so I think my job is to continually move my organization towards better quality delivery at greater scale. So like in the space of telesitting, for instance, I think the hospital should be a safe place, period, full stop. Like I would love a circumstance in which we don't have to risk stratify the delivery of a visual environment that creates better safety, and that we just basically make the place safe. So that's my goal, right? I'm working towards that goal. And so my goal is to get that thing done. My goal is not to get rewarded for it. My goal is not to get the sort of credit for it. And as much as it's important to get conviction from your leadership about a decision to go forward, even better is to get when I can go into an executive leadership meeting and agree with the idea that they are espousing. Like ideally, I've put that idea in their head, but like, I want them to take credit for it. I want it to come from them, and that means having gradually built up these conversations, having laid the groundwork with data that leads them to that solution, understanding what the burning problems of your organization are and how it is you can move them in that direction, and then having other stakeholders that you're bringing along with you so that your executive leadership said, oh yeah, Ethan said that interesting thing,
Yeah.
and Bill said that interesting thing, and I had that same interesting conversation with Lynn Marie. Like this is clearly a thing that's happening in my organization that I'm gonna pull together as an executive and get behind. And that's the far better long-term scalable solution than me coming to a presentation in which I feel like I have a clever idea and I
Yeah.
spend the time espousing that clever idea, and get to a pat on the back as opposed to conviction about movement forward.
Yeah. And let's talk about some of that legwork, because I think one can underestimate how much legwork needs to be done in order to make a case if you are really talking about something transformational. So you talked about kind of gaining some support, throughout the organization, and not just coming in at one crucial presentation. There's so much more. And then you talked about this some at the ATA conference as well, is as you're sort of gathering data and understanding the problem, what are some of the data points to gather, and what are some of the questions to ask to really get at the problem? Because you're absolutely right. You have to start with the problem that you're solving.
Yeah, I mean, I think that the some of the questions that we ask as we sort of go around and look at people's workflow are, what would you do if you had more resourcing, which is something people love to talk about. Like, now you have to be careful to make sure you're not saying what would you do with more people, but like what are the things that you're not doing that you'd like to be able to do? What are the things that you feel like someone else could be doing? What do you spend your time doing? So a lot of this is data gathering that's pretty, interview, standard process improvement kind of stuff in terms of information gathering. Now, I work in an innovation institute, and so our job is not, we try to make sure that our job is not just about process improvement, although sometimes the information gathering looks the same. We're really looking for discontinuous change. And so we're really looking for opportunities not just to kind of make it 10 or 20% better, but 100 or 200% better. So often all of that data collection is really useful, but it's not really about incrementally responding to what people say in those data sets.
Oh, so are you
Yeah.
mean by that? I live in Michigan, and sometimes we'll quote Henry Ford. He
Yes.
said,
That
if I
quote
asked
on the
people
door
what they
by office.
wanted, he would say faster horses.
Yes. Yeah.
Yeah.
No, that's
So
exactly.
yeah.
Yeah.
So
You haven't visited me in my office. That quote is on the door of my office.
Is it really? No, I did not know that. We didn't talk about this earlier. Because
Right.
how do you get really?
But it's boiling back to the, what we're trying to do is actually gather data around the outcome as opposed to the process. Like, so you're really, that quote really differentiates a process improvement versus an outcome change.
Right.
And so if, again, very concretely about the work that you and I have primarily collaborated on is, I don't want patients to fall down and get hurt in my hospital, right? And the incremental solution is more eyeballs on people.
Yes.
And the step change
How do we
solution.
hire more sitters? How do we, let's
Right.
try different kind of non-skid stocks.
Right. And like probably although those things are part of a process improvement with better data, but I think one of the things that we learned here in terms of, like, again, getting to conviction is often when you take these kind of big bites of the apple of process change, is that the data infrastructure that exists currently doesn't actually aggregate data in a way that actually lets you look at those big step changes, right? So in our institution, for instance, we were recording falls in all kinds of different ways. We were also doing observations, sitting, in all kinds of different ways, some of it well documented, some of it not well documented. So part of our journey on really even building a case around transitioning from in-person sitting to remote visual monitoring was about actually improving the data infrastructure of what we were doing currently, because it actually wasn't obvious how much sitting we were doing, and it wasn't totally obvious the conditions leading to fall and whether patients who fell and had injury were monitored by sitters or not.
Yeah, often
And
that's
so there was a whole data picture that we had to go back and build before we
yeah.
could actually say at the executive level, here's the thing we've been missing in our data story. We knew it to be true because we went out and asked people, and because many of us are clinicians that knew these things to be true in our own experience. But it wasn't, again, to my point of scale, it wasn't aggregated in such a way as to be able to tell a system story. We were telling lots of small stories, but not a system one. So we had to go back and build the data infrastructure to get folks to conviction, to actually say, oh goodness, we actually are spending a lot on sitting, but it was kind of below the radar how it was getting spent, because it was getting spent in ways that actually just sort of pulled and borrowed from all kinds of other places.
Yeah. And to get to the idea of financial storytelling, and maybe thinking of different solutions besides virtual sitting, like virtual nursing or physician specialty consults virtually, or any different solution. What are some pitfalls to that as you're, and what are some advice about how to kind of marry the outcomes to the intervention that you really look?
I think that financial storytelling is probably a useful skill for every executive audience that you might engage with. And I think it's a little bit of a misconception to think that only your CFO is concerned with financial storytelling.
Yes.
There is no healthcare executive that's not actually financially astute. Everybody needs financial storytelling. But the storytelling for different leaders is slightly different. And it's really important that you don't get your audiences confused. And then when and if you get that opportunity to pull all those audiences together, ideally you're hitting the highlights from each of those different constituencies, right? So if you're engaging with your chief nursing officer, like that's a person who manages the finances of an enormous organization, right? In our organization, it's 8,000 employed nurses, right? That's a big bucket of finances. And so CNO, just because they're not the CFO, that does not mean that that CNO is not financially astute and needs a financial story. But that financial story for the CNO is a different set of metrics. It's about recruitment, retention, turnover, well-being, growth, flexibility in work. It's about a bunch of things that you can actually drill down to financial metrics that CNO actually believes deeply, right? That you don't need to convince a CNO that if you can recruit, retain, and keep happy your nursing staff, that you'll have better financial performance. That doesn't necessarily translate though to your CFO, right? Yeah. So your CFO knows, like in general, that nursing turnover is a problem, but they really want to see they want to see premium spend, right? They want to see overtime. They want to see locum spend. They have a different angle on that, which is not the same angle as your nursing leader, and making sure that you get that crisp communication. Again, in many of these conversations, you're going to have 2 or 3 sentences that start with, I have a methodology for us to be able to reduce our premium labor spend in nursing by reducing X, Y, or Z. That's the story to your CFO. I think, kind of a related story of pitfalls is taking a length of stay argument to your chief financial officer. Your CFO has heard dozens and dozens and dozens of length of stay reduction initiatives and probably hasn't seen the needle move very much. And also, even if the needle is moving, the causal relationship between any particular intervention and length of stay, which is so multifactorial, is such that no CFO is going to give you prospective credit for a business case that suggests this intervention is going to move this length of stay by this amount. It's just far too complex a metric to be able to suggest that it's going to move. And I've not yet met a length of stay argument that our CFO will respond positively to.
Yeah. I think I heard someone say that if you go on like HIMSS exhibit floor, you could stop anywhere and get a chocolate and a reason why they're going to decrease length of stay for you. But I think that that's not hopeless though. I think there is you need to build up step by step. And another related example is like 30-day readmissions. Many different tactics are going on at the same time to address something like that. But if you kind of build towards it with leading metrics, then when you get there, it's more clear, the attribution is more clear. And for example, virtual nurses will keep track of their near misses. That when they're discharging a patient, we found this error and corrected it. There was 137 of these per month on discharges with our CHF patients. So then when you're decreasing readmissions with CHF patients, and you can really tell the story, the financial story that way.
Yeah, and I think doing the back to your point about like what legwork do you have to do to begin to build these stories, like understanding all of those various increments and all of the lead measures they're going to move these things is critical, right? So like if you can say not I'm going to decrease your length of stay, but I'm going to decrease the increment from the discharge order to a clean bed.
Yes.
Right. And that's the kind of, the storytelling of like an incremental move where you can say, and it's measurable to say the current lag in hospital X between discharge order and the patient leaving the room is 140 minutes. And after intervention, the lag is now 90 minutes. Right. And that's a real thing, but only if your environmental services actually turns the bed over, and only if your capacity management function identifies the bed and turns it over. So even if you move that metric, you have to prove that you can link it to the rest of the system to make that reality true. So shrinking the 50 minutes that I just described doesn't matter if the bed doesn't actually get assigned and cleaned and turned over and a new patient put in that bed. You got to do that work.
This brings me to a really good concept that you also shared when you're looking at something pretty transformative. Before you really, one of your steps is to do a pre-mortem.
Yeah.
So talk about that a little bit.
Yeah, I like this pre-mortem idea, which is I actually, in the circumstances in which I'm using large language models to kind of help me think through stuff, I often use this prompt with a large language model, which is, imagine this has all gone wrong. Why did this happen? And using that question of like, okay, everybody's super excited. This is all going to be gangbusters. It's going to be so great. But like, let's imagine it's all failed. Why did it fail? And you'll often get an answer of that's something that's super obvious, right? That you just like, oh yeah, that's definitely going to fail, right? So I think, for instance, in circumstances like in the work that we've talked about, is when you ask that pre-mortem question, why is this going to fail? Someone's going to say, we don't actually have the network in our hospitals to be able to manage that new load, right? Like you can put all that up, you can change all the workflow, but your network's not actually capable of doing that. And unless you start asking those pre-mortem questions about what's going to go wrong, then you can often sort of, again, be enamored of your solution before you've gotten very far down the road. And then you get into a situation where you're trying to plug in, a high bandwidth need device into a place that's never going to work.
Yeah. And so, that's a great example. So you need to come up with an alternative solution for that. I had a mentor tell me one time, you know, be careful about falling in love with your own ideas.
Yes.
Which is really hard if you have an innovator's heart,
Yeah.
which I think probably we both do.
I think that's true. And I think that actually, like, the pushback that I often give to folks who are sort of like, you're enamored with your solution, is you're spending too long admiring your problem, which is the sort of flip side of being impressed by your solution. Is, I'm sure you've been in these meetings in which the entirety of the meeting is glamorizing the problem, as opposed to thinking about, like, how does one move forward, to basically just sort of say, well, that's just too complicated, that's just too complex a problem, and this is why it's complicated, and this is the other reason that's a problem, and here's this, like, strange edge case over here that this solution's not going to solve. And you just basically end up in a circumstance in which the problem admiration eats up all the oxygen of the energy of the space, and you leave that meeting without conviction, which is where we started, right? Which is like, okay, complicated problem, not going to solve the world here, but, like, how do we move forward to make progress against these difficult problems?
Yes. Oh, I think that's a great place to end, kind of the balance of like focusing on the problem, but then, like, at some point you got to go with the Nike tagline and just do it.
Yeah.
And not the analysis paralysis that happens.
Yeah, like, again, a lot of folks who are sort of innovation oriented often have solution strategies that are really, like, big architecture redesign. And I think blending between big solution architecture redesign and that paralysis that you described is finding the discrete area where you can begin to make change, a sort of wedge opportunity. Begin to make that change, get the stakeholders involved, begin to make some incremental movement in a way that makes some sense. Not a pilot, but something that's really towards prototyping and towards scale and momentum, so that you can begin to hang these other capacities off of that original solution.
Well, we only have like 2 minutes left, or I would go down the rabbit hole of, like, pilots.
We don't use the word, actually.
Yeah, so go ahead and tell me why do you not use that word, and what word do you use instead?
I mean, we do experiments. We have a hypothesis. We do an experiment. It works or it doesn't work. And we only do things that we have we only put real energy into things that we actually have an expectation will have scale impact, right? So we definitely do experiments. We definitely build prototypes. But we know that sometimes a pilot can run forever. And what a frontline clinical staff hears when they hear pilot is, this is something I can outlast.
Yes, okay. Yeah, that makes a lot of sense. Well, we started out, and I didn't mention this, but you were kind of saying we want to hear from others as well. We're all learning how to do this better. So those that are interested enough to attend this session, I'm sure they have learned things too, and I'm always looking for additional pearls of wisdom. So please feel free to reach out to either of us. And thank you so much for taking the time to share some of your wisdom, and I think maybe just a little more effective.
Thanks, Elizabeth.
Yeah, thank you.